Nazywam się Jakub Gierczyński i chciałbym teraz zaprosić do wykładu i bardzo podziękować za udział w tej konferencji panią profesor Avivę Fattal Valevski i panią doktor Liorę Sagi z Izraela. Bardzo jesteśmy ciekawi, jak doświadczenia Izraela jako jednego z wiodących krajów, jeżeli chodzi o diagnostykę i leczenie SMA, mogą być zaimplementowane w Polsce. Uprzejmie proszę pani profesor i pani doktor o wygłoszenie wykładów.
Thank you very much, and thank you for inviting me to give this talk. Yeah, I'm sorry that I will repeat some of what is said now, but I'll try to not to repeat it all. And I will try also to speak slow so you can have all the translations. So when we talk about SMA, we know that the treatment up to the last years was only the standard of care, which included the ventilation assistance, physiotherapy, nutrition support, and patients were encouraged to pursue regular education program considering their normal cognitive ability. But since last year, and you mentioned already that they have 3 new treatments. The first one that was introduced is the nusinersen in 2016. And the second one was the gene therapy in 2019. And this year, the FDA approved the risdiplam, which is an oral therapy. So we know that nusinersen, that is given already in Poland, is an antisense oligonucleotide, and it modulates the SMN2 gene, which is the backup gene. It is approved, at least in Israel, for all types of SMA, but I hear that in Poland only for SMA type 1. The gene therapy, or AVX-101, is given only once, IV treatment. It's by AAV9 vector, and it is approved only for patients under 24 months, under 2 years of age. In the United States and in Israel, and I think in Europe it is approved for even older children, but according to their weight. And the third one, the risdiplam, is also works on the SMN2. It's an oral therapy. It's approved only in children older than 2 months, but any age after that. Of course, I will focus today on the gene therapy, on Avexis, because you already know the Spinraza that you have a lot of experience with it. And this is really a kind of a revolution, because we can see it's given intravenous, it's only single treatment, and it is given by a vector. The vector is the virus. The virus is called AAV9, and you can see here the virus, and inside the virus you see the DNA that includes the gene that is missing, the SMN1 gene. So here we see the cell, the neuron cell. Here we see the nucleus of the neuron, and the object is to introduce the DNA of the missing gene inside the nucleus. So when we give the injection to the blood, from the blood, the virus that has already inside the DNA, it enters the cell by an episome. It's called an episome. It's like a vesicle that is called an episome. In the episome, it is incorporated in the cell, and it moves to the nucleus of the cell, where the DNA is forming. The DNA here is forming like a ring, and this is not incorporating with the normal DNA of the cell, and this ring of DNA produces the messenger RNA that again goes out to the cytoplasm, where it synthesizes the protein that is missing. So this is the way that the gene therapy works. The virus, the AAV9 virus, is an adeno-associated viral vector. It is a virus that has a lot of good things. It crosses the blood-brain barrier, which means it can enter the neuron cells. Especially it targets neuron, but it also targets the liver. That's why we see the liver function test that might be abnormal after the treatment. It is a non-pathogenic. It is modified to be non-pathogenic and non-infectious and non-integrating. You saw that it's not integrating into the DNA of the cells, so it cannot cause any other like a cancer or anything that previously happened after gene therapy. And it is very rapid and sustained SMN expression, which means that's why we don't need to repeat the dose again and again. It is stable. Okay, this is the DNA that includes this blue part is the human SMN transgene. Okay, so we see a lot of advantages in giving this treatment. First of all, it is a one-time treatment and no need for repeated dose. Second, it addresses the cause of the disease by replacing the SMN1 gene, not like the other medication that work on the SMN2 gene. It is well tolerated. It is given intravenous, no need for intrathecal or some procedures. And there is only transient liver enzyme elevation, usually without any symptoms. And this problem can be prevented by oral corticosteroids. So we see that the advantages are much higher than the disadvantages. However, we have some challenges. The first challenge is to give it as early as possible. It is very important to diagnose the patient early and to give the treatment as early as possible, and I will talk about it later. The second challenge we have is how to select the patient, who is the right patient, especially if we want to switch patient from nusinersen to gene therapy. How do we decide? I will talk about that. And about the patient's expectation. We don't want the patient to expect, okay, we give IV gene therapy and tomorrow the child is running out. And of course, the monitoring after the treatment, which Dr. Sagi will talk about. She will talk about all our group of patients and how is she doing the monitoring of side effects of the treatment. So we will talk about the importance of early diagnosis, as you mentioned before. So we know that SMA type 1 begins even early in the perinatal period. And it's beginning with irreversible loss of motor neurons. And by 3 months of age, there is already severe denervation, already in 3 months. And in 6 months, we have 90% of the motor neuron are lost within 6 months. So we see that here we have a very narrow window of opportunity of giving the treatment. So the best results even occur when we give the treatment before there is a significant motor weakness or loss. So that's why we have to do it fast, but unfortunately, there is always diagnostic delay. It's very common in SMA. And some patients already progress before we give them the treatment, which is something we want to prevent. So even if we could give them the treatment at the pre-symptomatic period, would have been the best. So what can we do in order to early diagnose the patient? We have two possibilities, either to do a carrier testing, which means to test the parents and to see when they want to plan any pregnancy and to see if they are carrier. This is done in Israel. since 2013. But the problem is that it can only identify 90% of the carrier, because the carrier frequency is determined by quantitative analysis of SMN1 copies by a test called MLPA. So when you test for number of SMN1 copies, if you find 2 copies, it's a healthy individual. If you have 1 copy, he is a carrier. But there are some patients that have 2 copies, but the 2 copies are on the same allele. It's called cis configuration. And the other allele has 0 copies. So in this case, the test find 2 copies. They find normal, healthy parent, but unfortunately the parent can give the baby or his offspring the 0 allele. So this is called silent carrier, and this accounts for 5% of the cases that is missed. A point mutation is also missed by this test, and de novo mutation is also missed. So all this together, we can miss 10% of the patient if we go by this testing alone. So this is what we do in Israel, and unfortunately some of the patients in our cohort were missed because of these problems. And another problem is that some population, especially in Israel, they don't want to do carrier testing, or they want, even if they diagnose the patient with disease, they don't want to go for termination of pregnancy, and this is another problem. So not all the patients are diagnosed by the carrier testing. So another method is the newborn testing. Newborn testing means testing every baby that is born, even before any symptoms appear. And here we know that in the United States, they recommended that, that the newborn screening for SMA will be adopted in 2018. In Europe, already some countries in Europe have introduced this newborn screening, and the first one were Belgium and Germany. I will just say something about their experience. Okay, so in Belgium, in Liège region, the study identified SMA in 5 of 35,000 newborns. So they tested 35,000. They found 5 cases before any symptoms by the newborn screening. In Germany, it was done a study in Bavaria and North Westphalia. They found out 22 cases in testing 165,525 newborn. Of them, you see that almost half were with 2 SMN2 copies, which mean they will be probably SMA type 1. 20% almost with 3 copies, and the rest have more than 4 copies. Here we had to decide what to do with these findings, and their recommendation was that if we find a case with 2 or 3 SMN2 copies, immediate treatment, giving immediate treatment, because they will probably one of the severe cases of either type 1 or type 2. With patients that had, or newborn that had more than 4 copies, they recommended to conservative follow-up. And the patients that were treated pre-symptomatically showed no weakness by 1 year of age, those patients. The German pilot, they updated it in another article in 2020, where they found 38 cases. And here they found 15 cases of more than 4 SMN2 copies. And one of those patients, 15 patients, they just followed because their recommendation was just follow up. Okay, so they follow. They didn't give yet treatment because maybe they will have disease only when they will be older. One of the patients became symptomatic at 8 months. Okay, so there was another working group in the United States of Cure SMA, working group in 2018. They were a group of experts, and they recommended to give treatment only for patients with 4 copies, not to follow up, but to give the treatment. So this is a debate yet. I said the second challenge we have is the patient selection. We don't think we have to give this treatment to every patient. So we developed an algorithm whom to give this gene therapy and whom not. So we start with patients that are naive. They didn't get any treatment. We see an SMA1 type 1 patient without any previous treatment. So as you know, the first step we do is testing for AAV9 antibodies. If the patient has antibodies, we cannot give him gene therapy. He has to go to Spinraza. If the patient has no antibodies, so then we have 2 possibilities. Is he symptomatic or is he non-symptomatic? If he is not symptomatic, great, this is the best candidate. He will go immediately to AVX101. If he is symptomatic, we have to see how symptomatic he is. If he is very severe, which means ventilation of over 16 hours or very severe contractures, we don't recommend giving him the gene therapy. We recommend going for Spinraza. If he is symptomatic but less severe, we recommend the gene therapy. What do we do with patients, that were previously treated with Spinraza? Because I think this is the case that you will all have to deal with, because you have a lot of patients are on Spinraza and they want to switch. Again, antibodies, yes, antibodies, you cannot go to gene therapy. No antibodies, we can see, did the patient started the Spinraza before 6 months of age? If he started before 6 months of age, so it means that he is preserved. He is preserved due to the Spinraza. Then we can give him the AVX now because his motor neurons are preserved. If he did not start early, if he started after 6 months, we have to see, is he very severe case? He would go to Spinraza. If he is a milder case, he will go to the Zolgensma. So this is what we use. And I think there was a case now that I heard in Europe that was not, that he had side effect or did not survive after the treatment. I think that if they would go by this algorithm, they wouldn't have given him this medication, so that we think that this algorithm is a good one. The next challenge I wanted to mention is the patient expectations. We don't want the patient to think that we give the treatment at any age to any patient and tomorrow the patient is cured. We know that it's not cure, it's just improving. So we want to manage the expectations. So if the patient is asymptomatic or pre-symptomatic and we diagnosed him because he had an affected sibling or by the newborn screening, and he's also treatment naive, we say this group has the best prognosis. The best prognosis, they might be or either normal or very good motor achievements. If the patient is symptomatic, but he is younger than 6 months, or he started the treatment before 6 months with Spinraza, so I mean he is older than 6 months, but he started the treatment with Spinraza before 6 months, so he also had a good prognosis, which means he might be able to stand or to walk. If he is symptomatic but is older than 6 months or started Spinraza after 6 months, but no assisted ventilation more than 16 hours. He has moderate prognosis, which means he might go to sitting, but not for standing or walking. And if he is symptomatic and severe one, his prognosis is poor. So we think that the parents have to really be aware of this prognosis before starting the treatment. And here it's a summary of the approval in USA, which is under 2 years. In Europe, it's 1 or 3 copies, and the weight under 21 kilo. In Japan, it's under 2 years. In Israel, it's again under 2 years. And for my last slides, so Israel is a around 9 million population. We have almost overall of 150 patients in Israel. This is the types of them. And in Israel, we have approval of the nusinersen since 2018 and the Zolgensma since 2020. All together in Israel, there are 150 patients, and 110, which is 75%, are in our medical center, Tel Aviv Medical Center. 40 of them are at the adult clinic and 70 at the children clinic, which means they're not all of them children, but up to 26 years are children, and about 50 of them are treated with nusinersen, and 10 that Dr. Sagi will discuss and describe them, the 10 of them are treated with Zolgensma. Most of them are type 1, but we have 2 patients that are type 2. Of those 10, 3 patients were switched from Spinraza to AVX, and 1 patient was switched from risdiplam to AVX. We have a team, as you mentioned, that it's a teamwork. We have a team of all these specialties in pediatric, neurology, pulmonology, and so on, so orthopedic, gastroenterologists, even endocrinologists. We have a team of healthcare professionals, physiotherapy, nurse, social worker, psychologists, and we collaborate very strongly with the adult neurology, with the pediatric intensive care, and with an interventional radiologist. Our workflow is that we start by clinical assessment. If there is a patient referred to us, we first assess him by a neurologist, pulmonologist, physio, dietitian, and nurse. If he is suspected to have SMA, immediately we send the genetic testing. We get the result within 3 to 5 days. We have a very strong collaboration with the Genetic Institute. After that, if he's confirmed, the diagnosis is confirmed, we invite him again and we take immediately the antibodies, and in the same time we take baseline tests for liver function, troponin, platelet, and the coagulation test, and body weight, because according to the body weight, they prepare the treatment. We schedule with the pharmacy that will get the treatment that is coming from abroad, and has to come immediately to the pharmacy, and we scheduled a date in the pediatric intensive care. And we know, when we know the date, we prescribe corticosteroids 1 day before the treatment, 24 hours before. And I will not go into the post-treatment follow-up, because Dr. Sagi is going to talk about how often we do the testing after the treatment. So we have some clinical and research project in the department, while our future project is really to develop the newborn screening in Israel, which is not very easy to do it, but we are trying. And these are the take-home messages. Again, what you mentioned before, the early diagnosis, the newborn screening, the patient selection, patient expectation, and multidisciplinary team, And thank you very much for listening. And Dr. Sagi will talk now about the 10 patients that we have treated with Zolgensma and how they are doing.